So the next talk is by my dear friend, Dr. Rajiv Jain, who is going to be speaking to us about endophthalmitis.
Very good morning to everyone. Can we have the slides on, please? Yes. So management of endophthalmitis revolves around intense medical treatment and surgical intervention with salvaging the eye and vision being the primary goal. So what are the symptoms? If a patient in first few weeks of surgery comes with blurred vision, pain, photophobia, swollen eyelids, redness in the eye, discharge, floaters, and sometimes fevers, then that should warn us about the endophthalmitis happening in that patient. What is our clinical approach? Thorough history taking is important, and it's very important to have the blood sugars of the patients controlled. But because we have seen that in endophthalmitis patients, if the blood sugars are not under control, the management becomes very difficult. And the symptoms you look for, the examination you look for, you start with the routine examination like initial visual acuity, which gives us some idea of the prognosis, which you can explain to the patient. You look for orbital inflammation, you look for eyelid, conjunctiva, cornea, anterior chamber, lens, vitreous, fundus. It's important to have a good look at the fundus because it may further help you in management, taking the decision about the management. This is what you see: intense marked anterior chamber inflammation, membranes, hypopyon. It's always important to look at the wound site because there might be a leak at the wound and wound infiltrate as well. Exudates all over the eye well. Hypopyon, and here you can see there is a bleb infection as well. So once you see hypopyon, you see bleb infection, you see vitreous exudation, then you are sure that this is endophthalmitis. But cases who present early with inflammation, there is always a doubt in the mind which entity is this, whether this is endophthalmitis, whether this is TAS, or it is lens-induced uveitis because of retained lens fragment in the anterior chamber, some fluffy matter in the anterior chamber. So with good clinical history and examination, you can actually rule out. But whenever in doubt, between post-operative inflammation and endophthalmitis with severe haze in the ocular media, it's always give benefit of doubt and make diagnosis of endophthalmitis and proceed accordingly. So what a routine case. So our clinical management nowadays is not based on whether the presenting vision is light perception or better, because what EVS has told us was that if the vision is light perception or worse, then you go for vitrectomy, otherwise you go for injections. But nowadays with improved surgical maneuvering and instrumentation, we go in for vitreous surgery quite early. So you take AC tap and vitreous tap and you send it for gram staining and culture. And another thing which I want to point out is nowadays we send a lot of these patients for exciton as well. And the positivity rate in exciton is PCR analysis, and they have different panels of acute endophthalmitis, chronic endophthalmitis, even for uveitis panel is there, where I found out that the results are very good. And most of the cases you find some organism and which help you in further management also. Ultrasound is, it helps. It's not mandatory, but we do it in all the cases to look for membranes, opacities, and whether the retina is attached or not, how is the choroid, and if you have to plan surgeries, then you have to plan your reports, whether the detachment is there or not, so that you can prognosticate the patient also. So the treatment protocol, the goals of the treatment in these cases is you want to retain useful vision, minimize the infection with antibiotics, limit the inflammation, and give patients some symptomatic relief. As I said, our choice of treatment is determined by the clinical picture and not whether the vision is light perception or worse. So we choose intravitreal injections if we can see retinal details. The red glow is very good, and that is the time we give go ahead with intravitreal injections. But if the retinal details are not seen, there is a poor reflex, and if after 24 hours after initial injection there is no improvement, most of the times we go for vitrectomy. And as I said, medical management along with the injections is the mainstay to start with. We give intravital antibiotics. Along with it, we give periocular, topical, and systemic antibiotics. We give steroids, topical steroids, systemic steroids if the patient is non-diabetic, and we have ruled out fungal endophthalmitis along with cycloplegics. So why intravital antibiotics? Because all of us know that there is poor penetration to topical and systemic antibiotics in the vitreous, and so this is a slide which is, I think, one of the most important slide nowadays. Is we all know that for gram-positive, vancomycin works in most of the cases, and till now most of us were using ceftazidime as first line from gram-negative. I don't know what the panelists use, but I have shifted totally to tazobactam plus piperacillin or imipenem for gram-negative. And there is a study going at LVPI. Dr. Das had presented recently with Dr. Savitri that in our subcontinent, it's always better to start with tazobactam plus piperacillin or imipenem rather than restrict yourself to ceftazidime. And the results are better with second line antibiotics for gram-negative. In fact, this has become first line for us nowadays. So as I said, medical therapy is intravital injections along with the oral antibiotics and steroids, and you use adjunct therapy along with it. Steroids are very important. Once you have ruled out that it is not a fungal endophthalmitis, steroids help in reducing the inflammation, and the symptomatic improvement is there. As I said, before the EVS, there was widely divergent opinions regarding timing of vitrectomy and when to do it. They found out that there was no difference in visual outcomes whether or not an immediate pars plana vitrectomy was done if the vision was light perception or worse or better. So they concluded that you have to do vitrectomy only if the patient presents with vision of light perception or worse. However, this study was conducted in 80s and 90s. At that time, our surgical skills were not that good. The instrumentation was not that good. So nowadays, as I said, our management depends on the clinical picture and the course of the disease. And why vitrectomy? Because it gives us early sample for vitreous culture to start the specific therapy. It clears the ocular media so that you can assess and see the retina and manage accordingly. It facilitates better diffusion and penetration of antibiotics into the vitreous cavity, and it removes the inflammatory debris. So, mind you, it's not the bacteria which is causing the damage to the retina and optic nerve and blood vessels. It's the toxins and the products which are there. If you have removed them to a large extent, you have stopped the ongoing damage. The only thing remains is to control the infection. So, the surgical technique includes, I have time. Surgical technique includes putting us infusion cannula. We prefer longer cannula. Earlier times when we were using 20 gauge vitrectomies, we used to have 6 millimeter cannula. Now with 23 and 25, the trocar cannula already they're long enough so that most of the cases you are able to visualize it through the second port. And another important thing is to have a good cutter and sharp trocar and cannula set. See, what happens is endophthalmitis case, they are referred by our colleagues, and we are supposed to operate these cases at lesser cost. But these are the cases where you need good cutters and new instruments, because once you are putting a trocar on cannula, you are causing traction to the peripheral vitreous. If the trocar and cannula are not sharp enough, you can actually cause peripheral breaks, which is a devastating complication in a case of endophthalmitis. So what I do is I charge more for my endophthalmitis cases from my colleagues who refer these patients to me, and I use these instruments only twice. Once I've used it, we ETO it, and I use it once more, then I discard it. So vitreous biopsy is an important step, where what we do is so we attach syringe to the aspiration port of the cutter. Cutter has got a as you can see, we have attached syringe to the aspiration port of the cutter, and with the no active aspiration, we go inside the eye. We can see the tip of the cutter. We start cutting at high cut rate, and slowly move from behind the IOL towards the core of the cavity, and then gently aspirate the material which has come into the cutter, and we take out this retractor outside, and whatever fluid is there in the tube, we take it in the syringe, and then we start the infusion after this step only. And after starting the infusion and after completing the vitrectomy, we send the cassette sample also for microbiology and staining. I think if a lot of membranes in most of the cases are there, and what we do is it's important to remove the membranes to have a good view before doing the vitrectomy. You enter through the anterior chamber. If the epithelium is edematous, don't be afraid of removing the epithelium. You can scrape it off. And these membranes. I was thinking of bringing it to the, so that I can show some steps of removing the membrane. Anyways. So you can go with Simcoe, remove the exudates in the anterior chamber, remove all the membranes so that you can have a good view of the posterior cavity. So pars plana vitrectomy for endophthalmitis has conventionally been taught to be a core vitrectomy. Because of increased retinal fragility and edema, there is always that risk of retinal breaks forming during vitrectomy. However, what we have seen is that retina is not that fragile. It's more fragile, more chances of creating breaks in the periphery, but the posterior pole is more or less intact, and you can actually go down. Don't have to induce the PVD in these cases, but you can go and see the details and come out. IOL explantation is not necessary in all cases. We try to preserve IOL as far as possible. However, in fungal and P. acnes endophthalmitis, these are the cases where you may have to remove the bag along with the IOL. And role of intraocular tamponade like silicone oil is controversial. It has no place in routine endophthalmitis surgery. However, if you encounter a retinal break or a detachment, then it is must. The advantage is it gives you a long-term tamponade. Your media is clear. You can visualize the retina. You can visualize the progress happening. And it is also said that it is a bacteriostatic tamponade. So the growth of bacteria is also hampered. These are so to conclude, our choice of treatment is determined by the clinical picture and course, not whether the vision is light perception or worse. And our goal is to do a safe and maximum vitrectomy as much as possible. Intervention early than late means whenever you have doubt, tilt your diagnosis towards infectious endophthalmitis and start the treatment. And complete rather than partial vitrectomy is reasonably expected to offer prevention of further retinal damage, irrespective of visual acuity. Thank you.
Thank you, sir, for this lucid and very all-encompassing presentation. You pretty much covered everything.